My name is Dr. Patricia Kim, and I've been a practicing neurologist at University Medical Center for 21 years. I completed my residency at Johns Hopkins, followed by a fellowship in neurocritical care. I've seen thousands of cases involving traumatic brain injuries, strokes, and disorders of consciousness. Nothing in my extensive training prepared me for what I witnessed with patient 4721. David Chen arrived at our facility on March 15, 2019, following a devastating motorcycle accident. The 28-year-old construction worker sustained severe traumatic brain injury with bilateral frontal lobe damage, diffuse axonal injury, and prolonged hypoxic episodes during transport. His Glasgow Coma Scale was 3, the lowest possible score indicating deep unconsciousness with no eye opening, verbal response, or motor function. Initial CT scans revealed extensive cerebral edema and multiple hemorrhagic contusions. His intracranial pressure reached dangerous levels exceeding 25 mmHg. We performed an emergency decompressive craniectomy to relieve pressure, removing a portion of his skull. Despite aggressive intervention, the damage was catastrophic. His pupils were fixed and dilated, indicating severe brainstem compression and likely irreversible neurological injury. Within 72 hours, David transitioned into what we clinically classify as a persistent vegetative state. His brainstem reflexes were absent, requiring mechanical ventilation for respiratory support. EEG monitoring showed severely suppressed brain activity with occasional theta waves but no meaningful cortical function. His family was devastated when I explained the prognosis. Less than 2% chance of meaningful recovery given the extent of damage. David remained in our long-term care unit for 5 years. His condition never varied, completely unresponsive to stimuli, requiring full nursing care for feeding, hygiene, and positioning to prevent pressure ulcers. His wife Jennifer visited daily initially, then weekly, finally monthly, as hope faded. Serial neurological examinations consistently showed no change in his vegetative state, with absent higher cognitive function. I performed routine evaluations every 6 months as his attending physician. His reflexes remained pathologically abnormal with decerebrate posturing, indicating severe brainstem dysfunction. Repeat MRI scans showed progressive brain atrophy, particularly in areas responsible for consciousness and awareness. The frontal lobes, critical for personality and executive function, had deteriorated significantly with enlarged ventricles indicating ongoing tissue loss. On March 22, 2024, exactly 5 years and 7 days after his accident, night shift nurse Rebecca Martinez contacted me at 2:17 a.m. with an urgent call. She reported that David had opened his eyes and appeared to be tracking movement around the room. I initially dismissed this as reflexive behavior common in vegetative patients, but Rebecca insisted this seemed different, more purposeful than typical eye movements. I arrived within 30 minutes to find David sitting upright in bed, eyes open and alert, tracking my movements as I entered the room. His gaze was focused and intentional, completely inconsistent with his documented vegetative state. When I spoke his name, he turned toward me with clear recognition. This level of awareness was medically impossible given his extensive brain damage and 5-year period of unconsciousness. "Dr. Kim," he said clearly, his voice hoarse from years of disuse but perfectly articulate. "I need to tell you about Martha Henderson." The name meant nothing to me initially, but his ability to speak coherently after 5 years of complete unresponsiveness was staggering. His speech patterns were normal with appropriate inflection and emotional content, neurological functions that should have been permanently destroyed by his injuries. I immediately began a comprehensive neurological examination. His pupils were reactive to light, a dramatic change from years of fixed dilation. He demonstrated purposeful movement in all extremities, following complex commands like touching his nose, then my finger. His muscle tone was normal despite prolonged bed rest that should have caused severe atrophy. These findings directly contradicted every principle of neurology I'd learned. Martha Henderson died in room 312 on March 8, 2024. David continued with disturbing specificity. She was 83 years old, admitted for complications of congestive heart failure. She coded at 3:42 a.m. but was successfully resuscitated. She passed peacefully 14 minutes later with her daughter Sarah holding her hand. His detailed knowledge of another patient's death was impossible. He'd been unconscious for 5 years. I checked our hospital records on my tablet while maintaining professional composure despite growing unease. Martha Henderson had indeed died in room 312 on March 8th, just 2 weeks earlier. The details David provided were accurate. 83 years old, congestive heart failure complications, cardiac arrest at 3:42 a.m. with successful initial resuscitation, death at 3:56 a.m. with her daughter Sarah present. This information was confidential and impossible for him to know. She wanted me to tell you that the pain medication protocol needs adjustment for elderly patients with renal insufficiency, David said with calm certainty. The morphine dosing chart on the 3rd floor has been causing unnecessary suffering for patients with kidney problems. She experienced this during her final days and wants it corrected. His medical knowledge was sophisticated, using terminology that a construction worker shouldn't possess. Emergency blood work revealed normal electrolyte levels, glucose within range, and no evidence of infection that might cause sudden behavioral changes. His complete blood count was unremarkable. Arterial blood gases showed excellent oxygenation despite being off mechanical ventilation for the first time in 5 years. Toxicology screening was negative for any substances that could explain his dramatic neurological improvement. The results defied medical explanation. I ordered an immediate CT scan, expecting to find evidence of miraculous brain healing that could explain his recovery. Instead, the imaging showed the same extensive brain damage documented over 5 years: severe frontal lobe atrophy, enlarged ventricles, and tissue loss in areas critical for consciousness. The physical substrate for his demonstrated awareness simply didn't exist in his brain. Dr. Richard Kaplan, our department chief with 35 years of experience, arrived to evaluate this unprecedented case. He performed his own neurological examination, confirming David's normal cognitive function despite catastrophic brain damage visible on imaging. "This is medically impossible," he whispered to me outside the room. "His brain tissue can't support the consciousness we're observing. There's insufficient neural substrate for this level of function." David requested to speak with Jennifer, his wife who hadn't visited in 3 months. When she arrived that afternoon, their reunion was emotionally devastating. He demonstrated perfect recall of their relationship, shared memories, and personal details from before his accident. He expressed awareness of the years that had passed and grief over their lost time together. His emotional responses were completely normal and appropriate. "I was aware of everything," he told Jennifer and me during our conversation. "I heard every word spoken in my room, felt every medical procedure, knew when visitors came and left. I just couldn't respond or move. It was like being trapped inside a broken body while my mind remained completely conscious." His description of locked-in syndrome was clinically accurate, but inconsistent with his vegetative state diagnosis. Over the following days, I documented David's impossible recovery meticulously. His cognitive abilities tested within normal ranges on standardized assessments. He could perform complex mental calculations, recall detailed information, and engage in sophisticated conversations. Yet repeat brain imaging continued showing the same severe structural damage that should preclude any conscious activity. The contradiction was absolute and unexplainable. Colleagues from neurology departments at 3 major teaching hospitals reviewed his case files, imaging studies, and video recordings of his interactions. Each expert confirmed the medical impossibility. His demonstrated consciousness couldn't exist given the documented brain damage. Dr. Patricia Reeves from Harvard Medical School called it the most significant challenge to our understanding of consciousness in modern neurology. On March 29th, 1 week after his awakening, David began discussing Martha Henderson again with increasing urgency. "She's waiting for me," he said calmly. "The morphine protocol has been adjusted as she requested. Her unfinished business is complete now." When I confirmed that pharmacy had indeed revised pain medication guidelines for elderly patients with kidney problems, based on recent quality improvement reviews, his expression showed deep satisfaction. That evening, David insisted on walking to room 312, Martha Henderson's former room, despite being confined to bed for 5 years. His motor function was remarkably preserved with normal gait and balance. Standing at the threshold, he closed his eyes and smiled peacefully. "Thank you for letting me help her," he said to me. "Some connections transcend physical death. She needed someone to carry her message." I arranged for continuous monitoring given the extraordinary nature of his case. At 11:47 p.m. on March 29th, David was documented awake and conversing normally with the night nurse. Security cameras confirmed he was in bed, alert and responsive. At 11:52 p.m., the cardiac monitor showed normal sinus rhythm with stable vital signs. At 11:53 p.m., all brain activity ceased completely on continuous EEG monitoring. The nurse found him at midnight. Eyes closed, breathing ceased, no pulse detectable. Emergency resuscitation efforts were unsuccessful. His death was peaceful and instantaneous, without the typical dying process seen in brain-injured patients. One moment he was fully conscious and alive. The next moment he was gone. The transition was immediate and complete, unlike any death I'd witnessed in nearly 2 decades of practice. Post-mortem examination revealed the same extensive brain damage present throughout his 5-year hospitalization. There was no evidence of recent healing, regeneration, or any pathological process that could explain his week of impossible consciousness. The neuropathologist's report stated that the brain tissue examined was incompatible with the documented cognitive function during his final week of life. I personally reviewed every moment of security footage from March 22nd through his death on March 29th. David never left his room, never accessed computer terminals or medical records, never spoke with staff who might have provided information about Martha Henderson. His knowledge of her case details remained medically and logically unexplainable. The mystery deepened rather than resolved with investigation. Jennifer asked me to explain how her husband could have recovered consciousness with such severe brain damage, then died so suddenly after 7 days of normal function. I had no scientific answer to offer her. The case challenged every principle I'd learned about the relationship between brain structure and consciousness. My medical training provided no framework for understanding what I had witnessed firsthand. Dr. Kaplan recommended I present the case at our quarterly neurology conference. When I described David's impossible week of consciousness despite catastrophic brain damage, the audience of experienced physicians sat in stunned silence. Several colleagues suggested psychological explanations for my observations, implying I had somehow misinterpreted or exaggerated the clinical findings. Their skepticism was understandable but incorrect. I submitted a case report to the Journal of Neurology detailing David's medically impossible recovery and death. The peer review process was unusually contentious, with reviewers questioning the accuracy of my documentation despite extensive video evidence and multiple witness testimonies. The journal ultimately declined publication, stating the case challenges established neurological principles without sufficient explanatory framework. Martha Henderson's daughter Sarah contacted me 6 weeks after David's death. She had heard about his case from nursing staff and wanted to share something remarkable. During her mother's final days, Martha had repeatedly spoken about a young man who would help carry an important message after her death. She described him as having dark hair and kind eyes, a perfect description of David Chen. Sarah explained that her mother had been frustrated by pain management protocols during her hospitalization, specifically morphine dosing for elderly patients with kidney problems. Martha, a retired nurse herself, believed the standard protocols caused unnecessary suffering and wanted the issue addressed. She died knowing this concern might never be communicated to medical staff. David somehow conveyed her exact message about protocol adjustments. The morphine dosing changes David referenced had indeed been implemented hospital-wide after a quality improvement committee reviewed pain management protocols for elderly patients with renal insufficiency. The timing was remarkable. Martha Henderson's concerns, expressed through an unconscious patient who couldn't have known about them, led directly to beneficial changes in patient care protocols. I began questioning fundamental assumptions about consciousness, brain function, and the nature of awareness itself. My medical training emphasized the materialist view that consciousness emerges from neural activity. When the brain dies, awareness ceases completely. David Chen existed as living proof that this understanding might be incomplete. His case suggested consciousness could persist despite severe brain damage. Sleep became difficult as I replayed every interaction with David during his impossible week of awareness. His knowledge of Martha Henderson's case, his sophisticated medical terminology, his peaceful death exactly 7 days after awakening. None of it made scientific sense. I found myself researching near-death experiences, consciousness studies, and philosophical texts about the mind-body problem. Colleagues began treating me differently after word spread about the impossible patient case I'd documented. Some showed professional curiosity, others exhibited skepticism bordering on concern for my mental stability. Dr. Williams from psychiatry suggested I take time off to process what he termed a challenging patient loss with possible psychological complications. The implication that I'd imagined or fabricated David's recovery was deeply disturbing. I requested copies of all security footage, medical records, and documentation from David's final week. The hospital administration initially cooperated, but later claimed technical difficulties prevented release of certain video files. Several nurses who witnessed David's interactions reported being discouraged from discussing the case publicly. The institutional response suggested discomfort with events that challenged medical orthodoxy. 3 months after David's death, I attended Martha Henderson's memorial service at Sarah's invitation. During the ceremony, family members shared stories about Martha's nursing career and her passionate advocacy for proper pain management in elderly patients. Several speakers mentioned her frustration with hospital protocols during her final days, the same concerns David had mysteriously conveyed to me. Jennifer Chen invited me to lunch 6 months after her husband's death. She wanted to discuss the extraordinary week when David briefly returned to her. He was completely himself, she said tearfully, not just aware, but fully present with all his memories, personality, and love intact. Those 7 days were a gift I never expected. Her description confirmed my clinical observations of his normal cognitive function. I began documenting similar cases in medical literature, patients with severe brain damage who demonstrated impossible awareness before death. While rare, such cases existed in neurology journals dating back decades. Most were dismissed as observational errors or wishful thinking by grieving families. David's case was unusual only in its thorough documentation and multiple professional witnesses to his impossible recovery. The experience fundamentally altered my approach to patient care, particularly with individuals in vegetative states or minimally conscious conditions. I began speaking more carefully around unconscious patients, assuming possible awareness despite apparent unresponsiveness. Several families reported comfort from this approach, though I couldn't explain my changed perspective without referencing David's unexplainable case. A year after David's death, I applied for a sabbatical to study consciousness research at the University of Virginia's Division of Perceptual Studies. My proposal focused on investigating cases where awareness persists, despite severe brain damage. The hospital administration approved my request, possibly relieved to have me pursue these questions away from clinical practice, where they might impact institutional credibility. During my sabbatical, I interviewed dozens of medical professionals who had witnessed similar impossible cases. Patients with catastrophic brain injuries demonstrating inexplicable awareness or knowledge they couldn't possess. Many doctors were reluctant to discuss these experiences publicly, fearing professional ridicule. David Chen represented a documented example of phenomena many physicians had observed but couldn't explain. I returned to clinical practice with new humility about the limitations of medical science. While I remained committed to evidence-based medicine, David's case had expanded my understanding of what constitutes valid evidence. Direct observation by multiple trained professionals, detailed documentation, and verifiable outcomes deserved consideration even when they challenged established theories about consciousness and brain function. 5 years later, I still think about David Chen daily. His case changed not only my medical practice, but my fundamental worldview about the nature of consciousness and its relationship to physical brain structure. The week of impossible awareness he demonstrated before his peaceful death remains the most profound medical mystery of my career. I've stopped trying to explain it scientifically. Recently, I was contacted by Dr. Michael Harrison, a neuroscientist researching what he terms terminal lucidity, the phenomenon of sudden mental clarity in patients with severe neurological damage shortly before death. David's case fits this pattern, but with unprecedented duration and documentation. Dr. Harrison believes such cases might reveal important truths about consciousness that current neuroscience cannot yet explain. I've learned to live with the mystery of David Chen while continuing to practice neurology with the same scientific rigor I've maintained throughout my career. His impossible week of consciousness taught me that medical science, despite its remarkable achievements, may not fully understand the deepest mysteries of human awareness. Some phenomena transcend current explanatory frameworks while remaining absolutely real. The morphine protocol changes David conveyed from Martha Henderson remain in effect hospital-wide, improving pain management for elderly patients with kidney problems. Every time I review these guidelines, I'm reminded that his impossible consciousness served a genuine purpose, carrying forward the concerns of a deceased patient to benefit future sufferers. Perhaps some aspects of awareness persist beyond physical death. If I encountered another case like David Chen tomorrow, I would document it with the same meticulous attention to detail while remaining open to possibilities beyond current medical understanding. Science advances by carefully observing phenomena that don't fit existing theories, then expanding knowledge to accommodate new evidence. David taught me that consciousness might be far more complex than neurology currently recognizes. I continue practicing neurology at University Medical Center, treating patients with traumatic brain injuries, strokes, and disorders of consciousness. Each case reminds me of David Chen and the profound mysteries surrounding human awareness. While I maintain scientific skepticism and evidence-based practice, I now approach unconscious patients with greater respect for the possibility of hidden consciousness. Sometimes, late at night during hospital rounds, I pause outside room 312, Martha Henderson's former room where David Chen stood during his impossible week of consciousness. In those quiet moments, I feel a deep sense of gratitude for having witnessed something that expanded my understanding of human existence beyond the boundaries of medical textbooks. The mystery remains, but so does the wonder.